Okay, then thank you very much for this kind introduction. So I will talk today about inborn errors of metabolism and also the role of genomics, metabolomics and enzymology in diagnosing and monitoring those diseases. So what's metabolism? Metabolism are enzymatic reactions where substrate is metabolized to a product which is catalyzed by an enzyme. On the other hand, we have transporters which transport substrate from one cell compartment to another cell compartment. And this is Sir Archibald Garrett, who more than 100 years ago described for the first time an inborn error of metabolism. This was alkaptonuria. And we have now, we know about more than 1,000 different inborn errors of metabolism. And these are either due to enzyme deficiencies shown on the left side. This enzyme deficiency leads to a deficiency of an enzymatic reaction, leading to the accumulation of the substrate of this enzyme and lack of the product. On the other hand, we have transporter defects, which lead to the accumulation of the substrate in one cell compartment and lack of the substrate in another cell compartment. We have the so-called intoxication type inborn errors of metabolism, where intoxication is triggered by catabolism. This leads then to the accumulation of high concentrations of substrate, which then lead to an auto-intoxication of the body and the clinical symptoms. On the other hand, we have disorders of energy metabolism, which lead to cellular energy depletion, manifesting mostly as multisystemic disorder. As you know, every cell needs energy to function. And these are also called mitochondriopathies or respiratory chain defects. So first I come to the intoxication type disorders for the children with inborn errors of metabolism. The first days of life are critical. This is due to the initial catabolism. Every child loses weight after birth. This is due to the learning of drinking milk, and if the child is fed by breast milk, then it also takes some time until enough breast milk is produced. So every child is after birth in the first days of life in catabolism, and this leads in inborn errors of metabolism to an auto-intoxication. This is due to the fact that the caloric supply is insufficient compared to the caloric need. And this situation can also happen in later life during infection. Peak period for infections is 6 to 12 months of age. What happens during the catabolism? So if we don't have enough calories supplied via food, then the body has to rely on its endogenous reserves. So amino acids, fatty acids, and carbohydrates are released from the endogenous stores in an uncontrolled fashion. This is no problem for the healthy child, but in the children with enzymatic defects, one of these compounds cannot be completely metabolized, and toxic compounds, toxic metabolites accumulate in the body and lead to an intoxication. As a preventive measure, in many countries, we have a newborn screening program. In Germany, this is done nationwide on the second day of life. We have these filter cards where the blood is applied, and this is punched out in the lab, and then it is screened via this machine. It's a tandem mass spectrometry technique, which is now routinely used. Formerly, this is Professor Gastry who first described a screening test, a so-called Gastry test in 1961. This was also taken on these filter cards, also called nowadays Gastry cards. And initially, it was only a test for one amino acid disorder called phenylketonuria, where phenylalanine accumulates in the body, and a bacterial inhibition test was done. Of course, this was less reliable than the tests we now have in operation. So as already mentioned, the blood is punched out from these filter cards and then analyzed in this tandem mass spectrometry machine. This is done 6 days a week. On Sundays, the mail does not work, and so no new samples will arrive. And the principle is that butanol is used to produce butyl esters from the compounds which are in the blood. And these are ionized, and then they go through a first mass spectrometer, then they are separated according to their mass load ratio. And then we have a collision cell where these compounds collide with inert gases, and then we have characteristic split products, and these can be detected. So we get a whole bunch of different peaks, and every peak is represents a specific compound. For example, on the upper panel, you see here a normal sample, and on the lower panel, you see this phenylalanine elevated. This is a child with phenylketonuria or PKU. So these are the target diseases of newborn screening used actually in newborn screening in Germany. This is biotinidase deficiency, classical galactosemia, amino acid disorders like PKU, phenylketonuria, mild elevation of phenylalanine, and MSUD, maple syrup urine disease. Then fatty acid oxidation defects, most common the middle chain acyl-CoA dehydrogenase defects, and carnitine cycle defects, organic acidurias, glutaric aciduria, and isovaleric acidemia, and then 2 endocrinological disorders, hyperthyroidism and adrenogenital syndrome, and the newest addition is the hepatorenal tyrosinemia since March 2018. So newborn screening is done at 36 hours of life, and this is quite early, but due to the initial catabolic phase, then we have toxic compounds in the blood, and most patients we can then diagnose pre-symptomatically or during early phase of manifestation. Newborn screening is done, as you have seen, via metabolomics and enzymology. These are high-throughput techniques which allow a lot of samples analyzed in a short period of time. Also, genomics can be integrated into newborn screening programs in the absence of good metabolic biomarkers, for example, in cystinosis. So if the assay at the metabolite level is not possible, mutation analysis is done in cystinosis, where we don't have a good metabolic test. We can measure cystine leukocytes, but then you have to isolate leukocytes, which is not feasible from these filter cards. And we have for cystinosis a pilot project running in Germany where the 3 most common mutations are identified during newborn screening process. So the metabolite analysis for the other disorders is then supplemented with a genetic technique. For all other metabolic diseases, which are not target diseases of newborn screening, you have to have a clinical suspicion or suspicious history. So the pediatricians or the general practitioners have to be aware of the symptoms, typical symptoms, which can indicate inborn error of metabolism. And if we have a clinical suspicion, then a selective metabolic screening is done. Laboratory assay is done at the level of metabolites, so-called biomarkers, which is the most common technique. Then you can analyze enzymes. Some enzymes need cofactors to work, and so you can add or take out the cofactors in vitro. And finally, molecular genetics or genomics is also a modern technique. So the selective screening happens as follows. So if the patient is suspected to suffer from an inborn error of metabolism based on history or clinical symptoms, then metabolites are analyzed. If we have abnormal metabolites, then the specific enzyme could be tested, or other functional studies could be done in fibroblast to confirm the disorder, and finally also molecular analysis could be done. So nowadays we are in the era of genomics. This is due to the fact that gene analysis is more widely available. This is a quite robust technique. There are no pre-analytical errors in contrast to the enzymatic tests and also metabolite tests. Then we have the risk of some pre-analytical errors. Genomics is more comprehensive than doing tests at metabolite level or enzymatic level, and especially the techniques of next generation sequencing, whole exome and genome tests are really comprehensive. The costs have come down quite a bit, still expensive, but not as expensive as it used to be. So how do we do the laboratory diagnosis in inborn errors of metabolism in the omics era? So first, a patient is suspected to suffer from an inborn error of metabolism. And this is a classical way on the left side, which I have already described. But nowadays, often, especially in the absence of a good biomarker, of a good metabolite for this disorder, we also go straight to DNA sequencing to identify possible variants of the gene responsible for metabolic disorder. In the case of a patient with suggestive signs and symptoms and the presence of a good biomarker, it's more easier to go to the metabolite analysis first, and also cheaper and faster, followed by enzyme and assay and or Sanger or sequencing or other genomics techniques. For example, this can be done for Zellweger syndrome, where we have a good biomarker at metabolite level. So we analyze very long-chain fatty acids, and typically you get elevated levels of C26, and you can increase the sensitivity of this metabolic test by introducing this ratio C26 to C22, which is elevated in Zellweger's syndrome. So metabolite assay is commonly used for population-based newborn screening of intoxication type because it's fast, easy to do, and also cheap. And I already described high levels of substrate can be found in catabolism. For example, the classical disorder of intoxication type is phenylketonuria, a prototype of a one enzyme, one substrate disease. In this disorder, phenylalanine hydroxylase is deficient, which leads to the elevation of phenylalanine. And this can be used to do the diagnosis of PKU. And phenylalanine is a reliable biomarker in PKU. On the other hand, we have enzymes and cofactors which can be tested, and both metabolites and enzyme tests can be done as primary tests or confirmatory tests if inborn errors of metabolism are suspected. As an example for enzymatic testing, the biotinidase deficiency test is also a target disorder of newborn screening. Biotinidase is responsible for the metabolism of biocytin to biotin, which is vitamin H, and this is a cofactor for many enzymes, especially in energy metabolism. Clinical symptoms, if these patients are not treated by vitamins, is skin rash, alopecia, hearing loss, and severe mental retardation. Nowadays, we hardly see these symptoms anymore due to the newborn screening. Treatment is really simple, giving a biotin tablet, and the outcome is excellent if early start is introduced in the first weeks of life. We also have KM variants of enzymes, which we have to be aware of for biotinidase deficiency, for example. The blue curve is the wild type, normal, healthy enzyme, and the red one is a deficient enzyme. And if you test at different substrate concentrations, you also get different answers regarding the enzyme activity. If the enzyme test is done at substrate saturation, which is mostly done, then you don't see any deviation in this child with a red enzyme compared to the wild type. But in the body, in vivo, the concentration of the substrate is much lower, and then you should go to the low physiological range of the substrates, in this case biotin, and then you can see that the enzyme activity in the red curve and the mutant is much lower than in the wild type, and you would have missed this abnormality if you simply would have tested only a substrate saturation. So it makes sense to also test at substrate saturation. Not only at substrate saturation, but also at physiological substrate concentration. So here is another example of enzyme testing. So the residual enzyme activity is not expressing the flux through this enzyme. As you can see here, we have two enzymes. One's a CPS enzyme, both enzymes from the urea cycle, which serves to eliminate nitrogen and ammonia. And here, on the upper curve, you have the ornithine transcarbamylase enzyme, which is this enzyme. And you can see if you have 10% residual activity, the flux in the CPS enzyme is only 10%. In the OTC enzyme, the flux is 90%. So it makes quite a big difference what the characteristic of the enzyme is. So the pure residual enzyme activity does not mean much. So you have to be aware of these enzymological properties if you do enzyme analysis. And finally, you can also do molecular genetics, both primary and as confirmatory tests. In some disorders, there's no biomarker at metabolite level. For example, in mitochondrial disorders or respiratory chain defects, then it makes sense to directly go to molecular genetics. Even in the era of whole exome sequencing and whole genome sequencing, functional tests are of continuous whole exome sequencing or whole genome sequencing generates a list of genes which are defective and may be responsible for the clinical symptoms. The interpretation of new exonic sequence variants are often not straightforward, and this is even worse for non-exonic variants. So many variants are not tested experimentally, and the prediction programs are highly insufficient. So it's sometimes hard to say if a new variant is pathogenic or benign disorder, and sometimes you also have these variants of unclear significance, and functional testing can sometimes lead to reclassification of the variants of unclear significance to pathogenic mutation, pathogenic variant. So this is shown here. On the left side, you can see the classical way of doing the metabolic analysis. On the right side, patient with unspecific signs or symptoms, you can go directly to whole exome sequencing, whole genome sequencing, especially if there's no good metabolic biomarker. And if you find a variant of unknown significance, you don't know if this variant is disease-causing or not. And then you should go to functional testing, to biochemical studies, to see if this variant has an effect on the function. If you don't find a mutation and still have a high clinical suspicion of an inborn error of metabolism, also functional studies make sense. If you find a novel gene, you don't know what this gene means on a biochemical level, then you should also go to the biochemical studies. And if you find a known mutation, it's not essentially necessary to do biochemical studies. Then if it's a known mutation, it's fairly clear that this mutation is disease-causing. So genomics are a good metabolic tool in the absence of characteristic metabolite profile, for example, in mitochondriopathies. Genomics allows prediction of disease cause in some disorders. There's a good phenotype-genotype correlation. And genomics allows precision medicine for specific treatment options for single gene variants. For example, for the chaperone therapy in Fabry, only certain mutations are amenable to chaperone therapy. Genomics allows prenatal diagnosis in affected families. However, genomics is time-consuming if many disease-causing variants are known. Then, of course, you have the problem of variants of unknown significance, where further functional testing is highly appreciated. So metabolomics and enzymology on the other side are fast, high-throughput methods in case of good disease biomarkers, for example, newborn screening as a population-based preventive intervention. They have low to moderate costs, so they also are in line with the economics. Functional tests in case of presumed variants of unknown significance or benign mutations may lead to reclassification both at enzyme and metabolite levels, but you have to be careful when looking at enzymology. You have to be aware of KM variants, so you should test enzyme activity in the presence of physiological substrate concentrations, not only in the presence of substrate saturation. And metabolomics is also useful for monitoring of the therapy and inborn errors of metabolism. So metabolomics, enzymology, and genetics are complementary diagnostic tools. They lead to considerable progress in genetic methods in the last years and considerable lowering of costs for metabolic diagnostics. They may be included in newborn screening, and all three methods have a continued place in diagnosing inborn errors of metabolism, even in the era of genomics. So that's what I wanted to present to you, and I finished with a German poet and scientist and philosopher Johann Wolfgang Goethe, and I look forward to your questions and comments.